Thank you everybody for coming today. My name is Lauren and I work at PHA. So I'm just going to do a quick update. So thank you so much for joining us at this breakout session, the gray area navigating from pediatric to adult care. This session will run for 60 minutes. Panelists will briefly introduce themselves and share their connection to the PH community. These sessions are designed to be interactive and engaging through an in-depth discussion and question and answer period. Please save your questions until the special Q&A period of the session, and please do your best to ask general questions and avoid questions that are very specific to your experience so all attendees can benefit from the information. And we do have people watching at home, so thank you for joining us from home as well. Please join me in giving a warm welcome and thanks to our panelists for their time and expertise today. Go ahead. Yep, you're welcome to start.
Can you guys hear me okay? Good. My name is Anna Brown. I am a pediatric nurse practitioner at Vanderbilt Children's Hospital in Nashville, Tennessee. And I have been working in pulmonary hypertension for almost 10 years. It'll be 10 years this October, formally in the PH program. Prior to that, I was in the pediatric ICU and took care of a lot of kids in the ICU at PH. So PH has been very much a part of my career for over 10 years. And it's a privilege to take care of your children, and I feel honored to be here, and thank you to the PHA for having us, and excited to talk about what we probably need to do a better job of.
Hi, I'm Jody Petrie. I am primary caregiver for my daughter Taryn, who is 18 and was diagnosed in 2009. So we are just beginning the transition of all of her medical care from peds to adult care. We have not made the transition yet on her PH care.
Hi, and I'll echo what Anna said. Thank you for the opportunity to be here and hopefully share some insight. My name is Megan Cyrilis. I am an adult pulmonary and critical care provider, pulmonary hypertension provider in Murray, Utah. I did medical and pediatrics residency and am double board certified, so have a sort of special interest and background in both adult and pediatric medical care, and have a real interest in helping children transition to the adult world, sort of from my perspective on the adult side. So I think we were planning to go through just like 5 minutes each of sort of what our experiences have been and what the ideal transition would look like, and then we'd really like to spend most of the session being available for questions to have a more open discussion. So Anna, if you want to go ahead.
So we also recognize there was just a session about an hour and a half ago in the scientific session. Just by show of hands, did any of you guys join that as well? Okay, so maybe you can also teach us some stuff. I think we're going to overlap quite a bit in what was discussed there, but we have the added benefit of having a family representative and patient caregiver representative, which I think is going to be really valuable to the session. It will kind of keep us in check with kind of like what our ideal scenario is versus what happens in real life. So when we think about transition in the pediatric world, it's a really hard thing sometimes for families. Sometimes it's not hard because sometimes they really want to get out of our center. But I would say for the most part, it's a really difficult time. I mean, adolescent in general can be hard when it comes to things like taking your medications and understanding your disease and taking ownership of how to manage it. And so the big things that really come up in the pediatric world when we start getting into like the middle teenage years are when is it going to happen that we're going to transition, where are we going to go, and how is it going to happen? And so really those questions are going to be answered a little bit differently depending on your center. So I just sort of want to say that to begin with, that you know, I'm going to speak to what we do at Vanderbilt, and they'll talk about their specific experiences, but it's going to be a little bit different depending on where you're housed, and really about a conversation between you and your providers. But as far as when goes, it's not a hard cutoff age, but generally speaking, we start to think about transitioning to the adult center between 18 years old and sometime after finishing college, just depending on what developmental stage that the patient's in, where they're going for college, what life looks like after high school, and there's a lot of different factors that go into that make that decision right for the child. And I also should say that the transition period really starts long before that, because really starting in the early teenage years, I believe the American Academy of Pediatrics recommends to begin that transition period at age 13 for children with chronic diseases. And so that's what we do at Vanderbilt, is we start early teens, really just starting to shift a little bit of the focus of the clinic visit to that child. And so starting to talk to them directly, how have you been feeling? What has been hard for you? What are the names of your medication? What are the doses of it? How many times a day do you take that? What do they look like? Just starting to engage them in that that ownership of their disease process, because if you wait until the very end, it becomes very overwhelming. And a lot of parents do that naturally with their children, and some do it well before the teenage years. We have one sub-Q or Modulin patient whose actually 2 younger siblings help with the pump management, and they're only like 8 and 9 years old. So it can certainly happen before that, but we do try to formally introduce that into the office visits at the early teen years. And then as the years go on, it becomes more complex, talking about things like, well, how do you order your medications from a specialty pharmacy? And what do you need to do if you run into these roadblocks? And how do you deal with your insurance company or case managers at the insurance companies, so that they can really start to assume responsibility for these things? Because I think one of the biggest difficulties that I have heard, but of course would love to hear from other people's experiences, is that when you get to the adult program, there's a lot less involvement of the parents, and they really want to talk directly to the child / adult, and sometimes refuse to talk to the parents. And so it really, as much as you can prepare that child ahead of time, is good. That being said, even if you follow the most ideal world scenario, it's still going to be tough. I mean, I think that's an expectation that both parents and children have, that it's still going to be a hard transition, just like any other aspect of being an adolescent is. And so that's sort of the win. And as far as like, is it at age 18 or college, again, that's going to depend a little bit on your home institution. One thing that is hard for us, I mean, we would choose to keep our patients as long as we could if we were allowed to, but the reality is, at some point, the Children's Hospital is going to refuse to admit a 23-year-old. And that's really one of the things that we stress to the families, is like, we know you don't want to go, we know you've been here your whole journey, and we don't want to see you go, but we don't want you to be in a situation where you need to be admitted, and the Children's Hospital is refusing to admit you, and you're meeting your new care team for the first time in the hospital. It's just that it goes much better to have a more organized approach as an outpatient, where you can really get to know them and sort of see how things are different before you have to have a hospital admission. And so for us at Vanderbilt, when we get to that point, and this sort of speaks to the how do you transition, we are lucky because we have an affiliated adult center at Vanderbilt, and I recognize not every pediatric center is like that, or patients may go to college that is far enough away that they can't come back to Nashville for care. But in our particular case, most of our patients stay close enough, and we're able to transition directly to our adult team. And so we're fortunate in that we can have direct conversations with that team. They can access our electronic health record easily. It's the same one. And we actually have it set up in a way that I go with them to their first visit. So even though we're trying not to encourage hand-holding, we do. But it's a comforting thing for the family because they don't know their way around the adult side. It helps them find the right place. And it's just sort of like a more, I guess, apparent handoff of care. And so that's kind of how we do it, but again, that's probably not the norm, and I recognize that. So I think those are the main things that I had to say about from the pediatric end and what we strive to do. I get some feedback from our adult team on things that we aren't doing well, and that's sort of how we've come up with the plan that we have now. But we can hear from Dr. Cirilis about what it's like on the adult end.
Yeah, I think everything that you said sounds amazing, and I wish that we had that amount of structure at sort of in our Salt Lake Valley area. We have one pediatric children's hospital in the Salt Lake Valley, and then that would sort of feed into 2 different PH programs. I think in an ideal world, and for those of you that were in the other session, there was some discussion of how it's being done, I think at Texas Children's as well, and it is a lot more structured, and actually they have sort of an overlap visit where the pediatric provider can accompany the patient, or at least sort of help facilitate that first visit, and then even have an opportunity to go back to the pediatric provider after that first meet and greet visit to sort of summarize where things are at and any lingering concerns. So that would be wonderful in the ideal world. I think the reality is often that a patient just is said, okay, it's time to see a new doctor, and then they show up and it's terrifying, and we're both sort of in it together, I guess, kind of trying to figure out this immense history of this journey that the patient has been on. So the approach that I have taken to it is obviously to really study the chart and try to understand the path that the family has been on, because that can, if you don't understand that, I think as the provider, that can be really hard for people to feel like you are going to guide them in the right path moving forward if you don't know, well, they had this side effect with this medicine, et cetera, et cetera. And then I do really try to start to navigate away from the parent-focused to more of the patient-focused interactions in the visits, and I think that is where most of the tension does come from. But I guess trying to explore ways to balance that even in the sort of younger adolescents, where you're making sure that they're engaged with their care and talking to them directly so that they're prepared for that change when it does come to going to the adult side. I think the only other thing I would add, well, two other things. I think we also have the benefit of, I have the same electronic health record as the pediatric hospital, so it makes it very easy from a transition standpoint to be able to review the records. But I think if you weren't in that situation, coming up with a way to have almost a binder or, like an organized synopsis of the adolescent's medical records so that there is that track that can be reviewed would be really helpful. And yeah, I think the last thing, and we talked about this a bit in preparing for the session, was really that there will be differences, and Anna sort of brought that up as well, and that pediatric and adult providers do things differently, and even though there are guidelines, even the guidelines are different sometimes, and how often or how testing is being done may be different. And so I think having an awareness of that, a willingness of flexibility on both sides from both the provider and the family and the patient to say, okay, well, maybe we'll do it differently this time, or we'll think about a different path. But also, as patients and caregivers, just feeling really empowered to ask those questions and say, well, why are we doing it this way? We did it this way before, but can you help me understand sort of why you might want to go this route or something like that? Because I think that sort of open dialogue can be really important and helpful to educate both parties moving forward as a team. And that's how I approach it.
And then we get to the reality.
We're not very good at what we say we're doing.
Well, no, I think where we're at in the transition is kind of a blend. Our team started, I think, taking Taryn back without us, maybe at the age of 14 or 15, freshman year in high school, and they wanted to talk to her one-on-one, and to start preparing her for that. And started going through med lists, and I don't know, I think as far as they've gotten with questions about insurance and pharmacy is, do you know what pharmacy your meds come from, and do you know what your insurance is? Which she knows. And then they said, how are you going to order your medication? And then she said, I'm going to call my mom. And with our experience with specialty pharmacies and the challenges that we've had getting the appropriate supplies and getting what we ordered in one shipment, I don't want to put that on her yet. She just graduated from high school. She's going to be starting college. Our care team in March, she turned 18 in April. In March, she went in and they said, well, you're going to be 18 next month. we'll do our summer test, we'll do your MRI, we'll do your 6-minute walk. If everything's stable, you can set up an appointment with the adult team in the fall. And that was their transition plan. And they were trying to be reassuring, and they said, there's 2 PH specialists, and they said, you know, the other PH specialist has weekly calls with the adult team at the adult hospital. And it's like, but that's not her care provider. And so we pushed back, and we told them that we did not feel comfortable changing because she was going to be starting college. We're already transitioning, you know, her primary care provider and some of those other medical needs right now, and we didn't want to throw in another change. And they stopped and they thought about it for a second. They said, you know what, that makes sense. And so we've pushed it out at least a year. We said, not her first year of college. That's just too much. The expectation, and one of the things that's really been a struggle is going to these appointments, and they talk to her, and she'll answer some questions, and then she'll kind of shut down when they start pushing. And the nurse and the nurse practitioner have been pretty good about coaching her, but the doctor comes in, and when she doesn't answer a question right away, she says, you know, when you turn 18, you have to do this all yourself. And it's kind of like, oh, hold on. Because there are ways, and we can go to the appointments with her. And, you know, I've gone to some other specialist appointments with her in the past week. And I can sit back, and she can answer the questions, but then when it comes to, okay, when did this start? She doesn't remember. Okay, no, you've been doing that since you were 6. She's 18, she's not going to remember those types of things. So, you know, it's been a team approach more than sending her in on her own and thinking she's going to manage. Because 18 isn't a magic cutoff. I mean, it's not like all of a sudden you're going to be comfortable doing these things on your own. And so that's where we're at. We've kind of pushed and postponed, and I really like the idea of the meet and greet. I like the idea of, you know, having somebody who's been on her team since 2009. We've had the same nurse practitioner. To have somebody that's been on her team for that long join her for that first appointment, that to me sounds great. Because it's a medical provider that she's comfortable with, that she knows, and helps smooth out those introductions. And that's about all I have at this point.
So I think we're going to move into more of a question and answer session at this point. So happy to discuss any of the topics that we've talked about, or any other questions or issues that have come up.
Actually, can I say one thing real quick?
Yeah.
Something that both of you guys touched on that I think is a really good idea, even in a situation where if you're transitioning to an adult program that has access to your electronic health record, and certainly if you're going somewhere that doesn't have access to that, regardless, I think it's a really good idea to sort of hit the high point summary with your child of what the journey has been like with PH, from when they were diagnosed, any major milestones during that time, to sort of, even the healthcare team can probably read that in the chart, but I think it's really good for your child to have that understanding, because more than likely, back in 2017, when you were admitted for X, Y, and Z, there were other things that they were taking away from that hospitalization or that change in medication, and to have the sort of like understanding of why you were there and why we made these changes, I just think will help them be what we call a better historian. So like moving forward, they can, if there's ever a physician that says, well, let's try this medicine next, and it's like, oh wait, I did try that one time and it didn't work and this is why. Or it didn't work but I'm willing to try it again, like whatever it may be. But I just think sometimes, a lot of times, the children don't really know exactly what's going on in the hospital. And so once they reach an age of being able to take responsibility for that, for them just to have that understanding of kind of like what the full timeline is important.
I think from the last session, along with that exact thing, that, you know, I think also sometimes when children become adolescents, they're in that phase of life where the frontal lobe is not fully functioning, and they're like, why am I taking these medicines? This sucks. I want to be a normal teenager. And they forget the time that they were 10 and they almost died of their pulmonary hypertension because they don't have the cognitive ability to really remember those experiences. And so I think being able to, even though it seems a little bit morbid, but to review the history and say, this is how sick you were at the beginning, that may help to educate the patient or the adolescent on, you know, this is why we have to stay on these medicines, because we don't want to go back to that place, because I think that can be.
And we likely sheltered them from those things
Yeah.
at that time, right?
Right.
So, I mean,
Right.
you know, you don't have to like go into a lot of detail. We don't want to create fear, but
Right.
I just think for them to know kind of the things that they missed out on in the past as far as milestones go.
Yeah.
All right. Yeah, we can go ahead and open up the rest of the breakout session for Q&A, and I just have a few quick announcements. So when you want to ask a question, just raise your hand and I'll come to you with the microphone. Please speak into the microphone so others can hear you, and ask one question at a time. And if you know you're somebody who just has a bunch of questions, I'm just going to go around and ask. I'm going to go around to different people first and then come back to you. And we also have some questions on the live stream that we'll want to get answered as well. So yeah, thank you so much. And does anybody have a question?
It's not really a question, but I was at that former, the other meeting.
Yeah.
And some things that were talked about, I just wanted to just mention them.
Sure.
One of the things they mentioned is once you turn 18 and you're legal, then you have to give your parent consent to talk to the doctor. And so, I mean, we'd have to do that with it's my granddaughter. This is my daughter, Brandy. So, and then they mentioned getting a power of attorney, which I don't think you have to have that to talk. It's just a consent.
That was in the setting, I believe, of a cognitively impaired or developmentally
Okay,
delayed child,
right.
where you need to have basically guardianship
Okay.
of them when they turn 18, so you can continue to make medical
Okay,
decisions and stuff.
right.
Yeah. I mean,
Oh,
go ahead. I was just going to say it's never a bad idea to do a living will and or an advance directive with, you know, an adult, to at least start talking about those sorts of things. But it's obviously really difficult when you're talking to teenagers about death and stuff like that. But it's the reality of this disease, unfortunately. So.
well, and honestly, it should be something that everybody does,
Yeah.
right? I mean, we have that conversation with my 20-year-old stepdaughter, and she has no medical history. But you know, anything can happen. So you can also approach it from that standpoint of more of just like you're becoming an adult now. But I will say, thank you for bringing up the legalities of it, because it is true, we do have to sign releases once they turn 18, and that's even if you haven't transitioned programs, right? I mean, in the pediatric world especially, if we don't have that on file, we're technically breaking the law if a mom calls to ask a question and I talk to the parent and not the child. And the other piece of that too is, totally just blinked. I'll come back to that in a minute. I think you had another comment.
Yeah. The other thing that we talked about, or was talked about, is when do you, I mean, starting to talk about contraception with, you know, what we consider our children. And they mentioned, you know, 13 or 14-year-olds doing IUDs. And so, you know, that it's, you know, those are the other hard discussions
Yeah.
that you have to start. And
So I think that's almost a whole different bag of adolescent issues than transition, but it is a very real part of it. And I mean, in my world at least, that happens long before a transition, because we have to talk about birth control, and we have to talk about, you know, all the sex, drugs, and rock and roll, smoking, drinking, all of that. And I mean, I think that it's hard with adolescents, period. And then throw in having to manage a chronic disease on top of that. You know, I wish I had like a perfect strategy of having those conversations. I think birth control is hard for a lot of reasons, but I think when it comes to family planning with teenagers, we often end up having discussions too about how pregnancy is not recommended. And that's a really hard thing for teenagers to hear. And, you know, we really try and lean on the families as far as guidance for those conversations, because some families don't want to have that conversation until a certain point. But that's another sort of just added aspect of it.
You know, I think it's difficult because you said try to talk to families, and you know, all along it's a family condition, really. It's not just your child's condition. It affects the whole entire family, and then they turn 18 and it's their disease. And so it just makes it really difficult.
I know what I was going to say earlier is your comment about power of attorney. We actually have had one family in our practice who stated they didn't feel like their teenager was capable of managing their disease, and when they turned 18, they were going to take them to court to retain decision-making power. That was just a power struggle in that family. It was that there was, other than just being 18, there was really nothing. It's that frontal lobe we were talking about that's not fully developed. I don't recommend that route at all, unless you truly have a child with developmental issues that won't ever be able to make that independent transition. So.
Thank you.
We talked about a medical power of attorney when Taryn turned 18, and we do have one that has been signed and witnessed. It has to be witnessed. I'm trying to remember if we managed to get that done. Because as I looked at the medical power of attorney, if she at some point becomes incapable of making decisions, we've already got the paperwork. It's not something that I'm going to hold over her and say, I'm going to every appointment and you're not going to be able to make decisions. But I do think, you know, if she were to have a PH crisis, if she were to end up in the hospital, you know, somebody should have that information. But it's a discussion we've had. It's something that she knows is in case of an emergency. You know, she was more than willing to sign the authorization for me to talk to her doctors. You know, she's not comfortable bearing that sole responsibility at this point. But I think if it's approached, you know, it depends on how it's approached, and you know, for us, it's not a power struggle over who gets to make her medical decisions. You know, first and foremost, it's her choice. It was her choice at age 14 to try going off IV meds. You know, that was something that the doctors recommended. Her dad was against. I was for. But we said it. You know, in the end, it's your body, your choice. And it didn't work out. And you know, then we had to deal with the fallout of I make bad medical decisions. You know, from a 15-year-old. No, you didn't make bad medical decisions. It's just an unknown. And so, you know, with that history too, I think it was a little bit easier for her to sign on a medical power of attorney so that she's got support.
I just want to make sure to clarify the difference between guardianship and medical power of attorney, because we've been kind of using the terms a little bit interchangeably. But so guardianship would be that even if she was like awake and fine, you would have the ultimate say in the medical decisions, and she could be like forced to do whatever mom said, basically. Whereas a medical power of attorney, like Anna was saying, is basically something all of us can and should probably have, that said, if I was incapacitated, I would want this person to make my medical decisions for me. So just so we're clarifying that. And then I guess I had a question, or would like to sort of poll the audience or get suggestions from you as caregivers on, because the pregnancy contraception question is always really difficult, and how to broach that. And so as parents and caregivers, how would you sort of guide us to broach that, if anyone has any ideas, how to make that an easier discussion? Or it may just be, eternally difficult and awkward, and that's okay, but if anyone thinks of anything, feel free to share.
My daughter, she was diagnosed at 4 years old, and they told us all of it then. So we've been prepared for that discussion and conversation when it's time. She's now 11, so we're getting a lot closer to those types of things, but they just laid it all out for us at the get-go. And, you know, we're in the room, and she was there too. You know, you don't think a 4-year-old pays attention, but she did.
Yeah.
So she's known it the whole time she's been diagnosed.
Okay.
And I mean, in a way, it was kind of like devastating at the time because, you know, your daughter can't have children, you know, so, but then looking back, I'm happy that they did it that way, just so it's something that we could continually talk about over the years and prepare her for better.
Yeah, I think that's definitely one approach, is just to kind of lay it all out up front. Can be hard, though.
And I think also, I was mentioning if I had a special strategy to talk to adolescents about all these hard things, I think at the end of the day, it's just transparency. You know, we've done a lot of work with palliative care at my center and talking about a terminal illness, and I know this is sort of not what this panel is about, but just being transparent with your child about whatever it may be from an early age, because otherwise they start to feel alone, and they also start to try and protect their parents. And so whether it's disappointment around not being able to have children in the future, or something a lot harder to talk about, like your mortality, I think just being as transparent as you can with your children. And a lot of times we have conversations in pediatrics when the kids are very young and if they're diagnosed as a young child, that later you have to go back and have those conversations with the child when they're older. I'm impressed your 4-year-old was able to pick up on a lot of that stuff, but starting those conversations as early as you can and remaining transparent with them throughout the process. It's not going to change what's going to happen with the disease and what medications you're going to have to be on, but it's going to change the relationship that you have with your child. And in a good way. You may want to speak to that more.
So our child's doctor or hospital has told us that they can stay until they're 23 before they have to transition over to adult care. I did attend a support group for the doctor that was closest to us, pulmonary hypertension specialist that was closest to us, and one of the things I noticed was all of the other patients that were in that were much older. I mean, they were older than I am. And so with pulmonary hypertension being a disease that has many different causes, is there a benefit to keeping a child or a young adult as long as you can with the pediatric doctors, since they have more of the expertise regarding pediatric PH? Or like with Ava's example, Ava has a BMPR2 gene mutation and started symptoms at a young age, whereas, you know, some of the older PH patients probably have, you know, the secondary factors or other issues. And it seems like I'm comfortable with where Ava's at now because I know that they see patients like Ava all the time. And my fear is if Ava transitions to the adult care, they're not going to have that expertise. So is there a benefit treatment-wise to keeping them on the pediatric care as long as possible?
I mean, I would say no, but I'm an adult doctor, so. I guess a couple of thoughts came up just as you were talking. You know, you're right, probably in a support group for an adult PH doctor, you're going to see a lot more variety, and that's just the nature of pulmonary hypertension. And I think that the cases of group 1 or heritable PH are still being seen by adult providers, but they just get diluted out by a lot of other types of secondary pulmonary hypertension. I certainly think there may be conditions where pediatric providers have more expertise and experience, but I also think that the changes that happen in bodies and physiology and comorbidities that occur over, you know, when somebody becomes an adult, those may be better managed in the adult side. So I think you have to balance that a little bit. And I think in the ideal world, again, you know, it should be this fluid thing where we're all kind of on the same team, and yes, we may never have taken care of like this child or this person, but we've, you know, taken care of others like him or her, and then can also have open conversations with our pediatric colleagues. But my worry sometimes is that then the patient stays in a pediatric setting for too long, and sometimes there's just things that come up that may not be addressed the same way by a pediatrician that an adult doctor would think about them, I guess.
I think the only other thing I would add to that, I agree, like, your PH is not going to be managed any differently, I don't think, because the reality is we have very little pediatric data on how to manage PH, so we manage it like the adults do, you know? I mean, there's only one FDA-approved medication for children, and all of our treatment guidelines, for the most part, come out of adult data. And so I don't think that it will be treated any differently, I think it will feel different. And so I think from that standpoint, if you're in a position where your hospital will keep you till you're 23, I mean, that's great. Then I think at that point, you guys just have to decide when it feels right to go. And knowing that your PH is not going to be managed any different, it's just going to feel different. And I don't know if you have anything that you want to say regarding that.
I guess my struggle with the timing of the transition is I kind of expected that we would get through college before we were there, and I was speaking to another parent who said that Denver says we'll keep you through college because that's just too many changes. But our PH specialist is a cardiologist. We have a lot of known cardiac issues and perfectly fine lung function tests. But when we transition, the specialists are pulmonologists. And so what should my concerns be? I mean, now we're going to also now have to find a cardiologist, and because, you know, we've got these other underlying cardiac concerns. What's the difference? And why are many of the pediatric PH specialist cardiologists and the adult PH specialist pulmonologists?
I wish I had an answer for you. I have also found that very interesting. Again, I think it would be the same, that the PH will probably be managed similarly. But again, if it's a patient with a complex congenital heart disease that also has PH, you know, they may be better served with their primary provider being an adult congenital cardiologist, and then having, you know, some sort of backup or support from the adult PH person. I definitely think cardiologists and pulmonologists approach PH slightly differently just in the way we think about it sometimes, but I think that there are guidelines, and I think generally the PH care is very similar between the groups.
And I think also, this is all evolving, right? I mean, we've really been fortunate that we've been able to build bigger adult PH programs with children who are graduating from the pediatric programs and going on to adult life. And there are, you know, we're one of very few pediatric pulmonary-based pediatric PH programs, like very few in the country. But we are moving towards a multidisciplinary approach. We just hired a cardiologist to join our pulmonary team, and I know a lot of other pediatric teams are doing that as well. And so, but I agree, like, even we might think about things a little bit differently, but even like as far as it comes down to PH management, the new cardiologist that just joined us does things pretty much exactly the way that we do, even though she's cardiology and we're pulmonary. So the knowledge for PH really overlaps beautifully between the two, because it's a lung disease that causes heart problems. And in the adult world, all pulmonologists have had some exposure to PH. That's not always the case in the pediatric world. Not every pediatric pulmonologist has had PH exposure. Most cardiologists have. And so it does sort of add like another layer of trying to reorganize your medical home as an adult. But just again, to give reassurance, like what you were saying, whether it's better managed by pediatric versus adult or pulmonary versus cardiology, I really feel like if it's a PH specialist, you're going to be in good hands.
Any other questions? Oh, I'm sorry.
So basically throughout this whole thing, you have been talking from a parent to another parent or a doctor to a parent, but I am a 16-year-old who will soon be going into that. And how would you say that to someone like me, alternatively?
Which part of it are you, just in general, about how to successfully transition?
Like, what kind of process do I need to go through as, the one transitioning?
Yeah, I think that's a really good point, and thank you for bringing that up. And I think as doctors and parents, we do tend to talk above the child often, or the adolescent. So thanks for catching us on that. I would say the biggest thing that can prepare you for the transition is to just have ownership over your disease and your medications. And that's going to look a lot of different ways for different people. But if that means making a binder that's like your PH journey scrapbook, and it's got all the dates and CAS results and all of that in it, and your medications and stuff, so that you feel like you really understand it. And then again, also sort of making it known to your providers, like, hey, I want to be the primary sort of point person here. I'm ready to sort of make these decisions, or start thinking about making these decisions, and be more of the forefront of the visits. So I think it's just really about ownership. From my standpoint, like if you were to be coming into the adult clinic, that would feel like you had been prepared sort of as well as you could.
And I guess the only thing I would add to that is, that's a great question. Thank you, by the way. The reality is the gray zone from a legal standpoint really starts around age 16. From 16 to 18, there are some protective laws out there for teenagers who are not yet 18. And so I think every 16-year-old is going to be in a very different place regarding their ownership of their disease and their disease management. And so I think, first of all, I definitely agree, owning it is the most important thing. But when you get to that point that you feel like, I can do this, then speak up for yourself. And if you are ready to try and order your meds for the first time, or go to an appointment by yourself, or you want to sort of test the waters, it sounds like honestly you're a little bit ahead of the curve. And so, if you get there before your medical team is saying you're there, then let us know. And let us give you an opportunity to sort of like be more independent in whatever the issue at hand may be. Don't let us hold you back.
I think from a parent perspective, what makes me feel comfortable is that if you know your meds, you're filling your own pill cases, you know when things need to be ordered. If you're on IV or sub-Q and you're able to prepare your infusion medications on your own. My daughter was taking care of her central line site by herself by the age of 13 or 14. And so any questions about her site, the doctors would look at me and I'm like, she texts me pictures if it looks weird. That's the only thing I know about that, because she handles it all herself. Maybe going to, starting an appointment by yourself. Taryn's team would take her and they would go through all of their preliminary questions with her before they brought us back, just so that you can get comfortable being the person that's answering the questions, being there by yourself. But yet mom and dad are in the waiting room, or mom or dad or somebody's in the waiting room that can come in at the end, understand what the plan is going forward, make sure that hear that all the test results are good, or what the results were. And then, then you're that much closer to being able to handle it all by yourself. And your family members feel comfortable because they've seen the steps as well.
There's a nice algorithm, sort of flow chart published in 2013 via PHA. I don't know if we could somehow make that available, but it kind of does walk you through those milestone steps, and it has the role of the patient, the role of the parent, and the role of the provider. And I think that is something that even if you're not following, even if your practice isn't like using that algorithm, it's a nice outline for what you should be thinking about and where you feel like you are and where you want to be towards your independence.
I also feel like that pulmonary hypertension in teenagers is a lot less talked about. And whenever I was first diagnosed, I had no idea I would meet anyone my age with, you know, the same thing that I have, and I have only really met a few people that are in my age group and like me.
Yeah, I think we should and could do a better job of connecting adolescents, because it's a very difficult time of life as it is, and then you add on a really complex, life-threatening disease, and it's incredibly difficult. So we hear you, and I think we agree that we need to do better.
Thank you very much.
One of the struggles with trying to connect this age group is a lot of them don't want to talk. And they don't want to talk to somebody they don't know. They don't want to talk about their disease. They want to pretend that it doesn't exist. I think there's a bunch of parents online that have worked to try to connect their kids with other kids with the same diagnosis, and with limited success. Some of them just want to block off that part of their life.
That's fair.
And which then makes it a struggle to transition because you feel like a piece of them is in denial.
That's probably not an uncommon feeling for teenagers, wanting to just be in denial about it too, I would guess, because you just want to be like your friends, right?
Yeah.
So.
All right. Any other questions? All righty. Well, I don't know if our panelists have any closing remarks they want to share.
I just thank you very much for showing up today and for, helping. It's always good for me. I'm always humbled by my families. If you asked me to order some specialty meds from home, I couldn't do it.
Yeah.
I'll be honest, I couldn't do it. I couldn't manage with insurance companies the way you guys do. You guys are huge advocates for your kids, and it's totally normal and totally natural to have a hard time letting go, to let them go into that adult world and do all these things with just your guidance.
Just like to thank you all for coming, thank PHA for having us, and for creating a pediatrics track that focuses on some of these issues that we have with our kids.
I don't have anything else to say. Yes, agree. Thank you. And thanks for being brave to be here, and thank you for being incredible caregivers, because certainly this is a full-time job. And yeah. All right.
Well, yeah, thank you all so much for joining us today. And please remember to complete your evaluation forms after each of your breakout sessions, which can be found in the conference app. So if you go into the app and click on the agenda, and then click on this session, you'll be able to do a quick evaluation. And if you prefer to do it on paper, we do have paper forms in the Resource Center. And those can be submitted to any PHA staff member. And so please check your app or your program book to see what's next on the conference agenda. This is the last breakout session for the day, but there should be a medical update dinner tonight. And please help us by exiting the room. So, sorry, I'm just reading from this, and it says to prepare for the next session, but there isn't one. And so, yeah, thank you so much, and thanks again to our panelists. Thank you.